Okay, you're on.
All right. Thank you, Paul. Hi, my name is Dr. Richard Huynh, and you are watching CalCare Office Hours. This is Hcala and PNHP presenting CalCare for all of you. It's an opportunity to learn about CalCare, learn about AB 1400, spread the word, and answer any questions that anyone may have regarding this amazing bill that's coming out in California that will hopefully get guaranteed healthcare coverage for all residents of California. And so this is my first time being a co-host of this event. And so, but I've been on this event before just as a participant or viewer. But for all of you that don't know me, please allow me to introduce myself. My name is Dr. Richard Huynh. I'm a practicing physician down in the Torrance, California area. I am a pulmonary and critical care doctor. So I work on the lungs and in the intensive care unit. And I am part of Hcala leadership, and I am a part of PNHP, which is the Physicians for National Health Plan. And I am a fervent supporter of CalCare. And so I guess what we typically do at this point in time is we give a brief introduction about the with regards to the bill. Well, you're the best. So CalCare, or California Guaranteed Healthcare for All, is a solution to our broken healthcare system. It is a guarantee that healthcare is a human right and will provide comprehensive, high-quality healthcare to all, just as Medicare would do. Medicare for All would do nationally. So what does that mean? It means everybody in and nobody out. So irrespective of your race, gender, sexual orientation, country of origin, disability status, immigration status, marital status, age, income, it doesn't matter at all. As long as you're a resident of California, you are guaranteed healthcare in our great state. It is a single payer program, meaning that it is publicly funded but privately delivered. So instead of having these crazy healthcare or health insurance industries, looking at their bottom line, it means that all of us will be covered under a public program. It will give you complete comprehensive benefits, which would include dental, medical, hearing, vision, mental health, prescription drugs, long-term care, and more. It's everything that is Medicare and much, much more. It is more than any, and I mean any, quote unquote, gold or platinum plan healthcare insurance that you can think of. Out of all of my years working in health, I have never seen anyone have an insurance coverage that would be even close to what CalCare would give every single resident of California. And it is free at the point of service. That means you go see your doc, no copay, no premiums, no deductibles. You just arrive, show them your little card, and get the care you need. Heck, you can show up at your doctor's office and say, I haven't enrolled yet. And then guess what? They can enroll you at that period of time and you'll get the care that you need. It's that simple. It will also, and in the bill itself, they talk about just transition. That means that the funding and programs to protect and support any displaced workers in the insurance industry is provided. So no real loss of jobs here, except for maybe those high-end CEOs that are just banking off of your health, that are just taking making a profit off of your health. It is patient care based on patient need. So no more financial incentives to avoid providing necessary care. So none of this, denials and delays. It's about your care. Your care comes first, not the healthcare insurance company's profit margins. And that is CalCare in a nutshell. And look, Erika's here. Hey, Erika, how you doing?
Hi,
Thank you for.
I took it on myself to do that spiel that normally Gina Harris does an amazing job doing. I hope I did it justice.
You were amazing. You're always amazing. And thank you for just jumping right in and starting. And I apologize, I'm late. Of course, right when I was to get on, my 11-year-old was like, I'm hungry. And I'm like, really? Okay.
No worries, no worries. I kind of know it because we are warming up a bottle of milk for Allie as we speak. So I guess this is the beginning of things for us as well.
Yes, excellent. So, so I see we have a few people on. And Paul, do we also have people joining us on Facebook? You don't have to say the numbers, but
yes.
Oh, great. Okay, great. So, so here we are, Dr. Rich.
Here we are, indeed. This is, you know, I've always like imagined myself one day having like a podcast. So this is like, you know,
this is it.
This is like the start of that, I guess. If this goes well, this may be the start of a whole new career for me. Who knows?
I think so. So if this was your podcast, what would you do next?
I have no idea. You know, I've always just thought, you know, it'd be interesting to have a podcast. I have no idea what I would talk about though. But I guess in this case, we should talk about CalCare and how amazing it is.
Yeah. Well, this is the AB 1400 podcast with Dr. Richard Huynh. We've got our crew here, Paul Newman running web and Facebook. We have our favorite regular guests who show up, Danette. I see Dennis is on with us. So here we go. And then we have people out there in Facebook. Yeah, I really want CalCare. How about that?
I think that sounds reasonable.
Here's something just, I don't know, not very serious to start us off with, but is anybody here familiar with the TV channel Link TV? No. Okay. Link TV, it's channel 375 on your, if you have like, what's it called? Like direct TV, it's channel 375. Link TV is like, if you're familiar with KPFK, the radio station, Link TV would be like the television version of KPFK. So, and Link TV is what really started my whole venture, let's just say, into lefty activism and politics. And I mean, gosh, when I was first married, so this is, I've been married 20 years, so decades ago, my husband, of all people, said, I found this channel. I think you would like it. It's called Link TV. And he had no idea. It would change my life. So I started watching Link TV, and that's where I found the program Democracy Now! With Amy Goodman, which is a news program. Yes, so you're familiar with that. And that was like the beginning of like just everything. I was watching and I'm like, wait, that's not what I learned in, you know, history in college. And what's that? And then of course, you can only watch to a certain point and then you start taking action. So Link TV has great shows like that. And they have these great documentaries, and every now and then they'll put on a movie. Anyway, they had this movie on, it was called Mama. And I guess it came out in 2016 with Penelope Cruz. She's amazing. And it's the story of, and this is just a movie, but it's in Spanish, so it's subtitles. So it's shot in Spain with a Spanish director. And it's about an unemployed teacher who gets breast cancer, and it's her journey through breast cancer. And she's a mother, and it's this, you know, it's just a movie. But of course I watched the movie and it's so good. I love this movie. But I'm watching it, and of course I can't help but notice like none of the movie is about like, how am I going to pay for this? This is bankrupting my family. And by the way, her doctor in this movie, who is a gynecologist, and he sings. I want a gynecologist who sings, and he's devilishly handsome. But she's like the best healthcare. And so, of course, even when I'm watching a movie, and of course, you know, I'm just like, because this is what it's like. They don't even need to make movies about what it costs. They can just focus on unfortunately, just the suffering of the disease or the support that she gets through that. And that reminds me of a story. When I first met Maureen Cruz, I was at this event for Kimberly Ellis, and Maureen Cruz told the story, and it just had me like, I was like, who is this woman? I have to meet her. And here we are. But Maureen told a story about how she was in Spain, however long ago it was, and whatever it was, she got sick or something. And there's clinics like just in walking distance in all the neighborhoods. There's so many clinics, and you just walk into the clinic, and she got really great health care. And then she was like, okay, where do I pay? And they laughed and said, oh, you must be American. And I'm going to butcher the story. So Maureen, when you watch the, video and you're like, that's not exactly what she said. Like, okay, yes. But the woman said something to the, the point of like, here in Spain, you are a human being. And I was so shocked by that. And Maureen talked about here in America, and I think this is an actual insurance term. We're income generating units. We're income generating units. But in Spain, she was just a human being who needed healthcare and got the healthcare. So she wasn't even, a citizen. She was a visitor. She wasn't, even paying into their tax system, but she got great care. And so anyway, and that's what CalCare would do. CalCare would kind of restore our humanity. And when people needed care, whether it was healthcare or mental health care, we could just get what we needed. And that's why we're working so hard for CalCare. So yeah, that's my little story.
Yeah, I guess that might be a reason why there's never a movie about our struggles, is because it would be unique to the United States, right? Like the rest of the world would be like, wait, why is the premise of the story like you can't pay for your medical bills, or that your family's going to go bankrupt because you're sick? Most of the world would be like, that's so silly, it'd like break apart the entire premise of any movie. It's for the rest of the world, they'd be confused as to why we have such a broken
system. So it would just have to be for an American audience.
Right, exactly. It's like, and now with the globalization of movies, people are trying to get that global hit. Like you wouldn't get that.
So you're saying I can't make my movie? Is that what you're telling me?
You can.
Are you turning me down?
But you wouldn't win. I don't know if you can win at the Cannes Film Festival. You'd have to go local. You'd have to be like, Venice Film Festival. That's
Venice Film Festival.
It's amazing to me, just to piggyback on Maureen's story. Every so often, I think maybe about once or twice maybe 2 to 3 times a month, I'll see a patient who is from some other country or somewhere else in the world, and they will vocalize their dismay at how ridiculous our health system is, and how it doesn't make sense that the medications that they used to get in wherever part of the world was completely free, right? And now with suddenly hundreds of dollars per month, even though they have insurance, even though they have, whatever insurance plan. It's always fascinating to, when I talk to these patients, just get their point of view. And it's just, they like, and they always say like, oh, don't get me wrong, I love the United States, I love living in America, I love where I live, but this is ridiculous. I can't believe that, what I used to just get for free here, like, costs me, so much money. and it's always interesting to see how they almost took for granted, sort of where they came from. That was much like how we normalize, the system that we're in, right? We normalize the fact that we have to pay so much money for our own health, right? Which doesn't make any sense. They normalize, they had made it normal that they got all their stuff for free, which should be the norm, right?
Well, and this normalization is a huge problem, right? So I know that there were studies done, and this is the part that I don't know how to fight or deal with, but so very poor people in Appalachia, it is so ingrained in their psychology that only people who can pay for healthcare deserve healthcare. So they feel that they do not deserve it. So how do you, and so like, and if I'm like, if I'm there, with MedicareForAll or CalCare, we're up against, like, you would think that they would be on our side, but they're not, because they don't believe that they deserve it, that only the people who can pay for it deserve it. And everybody in this country has bought into, well, it's just so expensive. And we know from Dr. Belk and other people, Dr. Belk wrote a book called The True Cost of Healthcare that really shows the collusion between the insurance companies and the hospitals to keep prices artificially high. And you can't even get an itemized bill in your hospital. And part of keeping prices artificially high is keeping the prices from you. And then just telling you that it's very expensive. And so the more that, the more a hospital charges, that like the higher the hospital bill, the more money the insurance company makes, and vice versa. So there's a lot of collusion going on there. And also, which I'm not, when you get something, but you don't get it enough to be able to like teach it back. So I guess that means you haven't really gotten it. But, and then, there's a whole thing that goes on with our pharmacies as well. And so these three are all, tied in together. There's a middleman in the pharmacies, and I can't remember what they're called, but it's kind of like they've got the actual pharmacies by the, I don't know what you would say, cojones, and they're determining prices. They're something like pharmacy managers or something, but they're directly, working for big pharma, insurance companies, and hospitals, right? It's all linked. I do see we have a question, so I'm going to throw it to you. And it's from our very own Paul. Why do insurance companies deny drugs which can better the recovery of a patient? You got a take on that, Rich?
Sure. Yeah. I mean, I guess the answer to these questions always come down to money, right? To them, as we were kind of saying before, patients are not viewed necessarily as humans. They're viewed as so-called income generating units. And so insurance companies will sort of create these algorithms and figure out, what's best for their bottom line, right? So when I prescribe a medication, let's say, the insurance company is then looking into, well, okay, how much does that cost? And is it reasonable for us to pay this amount to give to the patient? Does it make financial sense to us? And they have to kind of look at, well, what type of recovery will the patient get? Will they continue to buy into our system? Will they continue to make money for us? Or is this patient now a net negative loss for us? And then it doesn't really, for them, right? It doesn't doesn't behoove them financially to make this patient better. That's probably the sad reality of it, right? And then you also have to factor in that insurance companies, right, they're going to try to cut every corner they can. So, you know, whether they can give the patient, let's say, the top of the line medication, or let's just get them by with something a lot cheaper, or that they have a contract with the pharmaceutical companies for, and let's start that instead, right? So, for instance, I think last week I talked about a patient who I prescribed a specific drug for, and the reason why I wanted that specific drug was because that's what the literature, that's what all the studies that had been done was based on that specific drug, and that's what has shown benefit for that patient, or for the patients who have who take that drug when you compare it to others. But the insurance company that patient was insured by did not have a pharmaceutical contract with that company. And so instead they would say, oh, well, why don't you use, you know, this other medication instead, something that they do have a contract for. Well, now we're in kind of this box where it's, well, that's not where the data lands on, right? That's not what's proven to be effective. So for the insurance companies, it's like, well, it's close enough, right? It's like when your kid says they want, I don't know, they want pizza, and you say, well, why don't you eat, you know, ravioli instead? It's close enough, right? It's not the same though. And so that's why insurance companies would try to figure out ways to kind of get around what the drug is.
Mm-hmm. And also, I would just add, insurance companies are not there for healthcare. They are a product. They are just selling a product, and it's all about profit. They don't care whether people are healthy or not, get better or not, or live or die. And in fact,
they do the opposite.
they have, sorry, go ahead.
They do the opposite.
Well, yeah, because their internal motto is delay, deny, hope they die. Because if they have people paying in money, the less money they have to pay out, the more they make. And then if the person dies, they get to keep all the money. So that's, you know, insurance companies are not there as to help people get better. They are just there to sell their products and make a profit. Paul, I see your hand up, and then I'll move on to Jeffrey Denton's next question.
Okay, I just wanted to share real quickly a quick story about this very thing. I have a friend who's on dialysis, and not having kidneys and having to spend a few years on dialysis. I mean, this person lost 100 pounds. She's down to 78 pounds. And on top of the fact that it depletes it increases your phosphorus levels. And they gave her these meds that caused her back to look like she was flogged, and she's suffering, and she couldn't sleep at night. There are literally scabs all over her back from these. They look like, you know, a bunch of giant pimples that were picked and then they coagulated all over her back. I mean, we're talking about 30 of them at least when she showed me. And this is the drug that she had to take to keep her phosphorus levels stable, and she was suffering. So she found out there's another drug available, and so she called the insurance company to get the other drug, and they would not cover it. So they would rather have her suffer, you know, and stay alive than, you know, throughout her life, the quality of her life, which she is entitled to. She's entitled to take the better drug, you know, but they would not give her the claim. And so now she's stuck, and she's trying to figure out how to maneuver around this, but so far she hasn't found a solution. So I just wanted to add that story about the insurance companies, how they don't care if you suffer. So anyway, that's my story.
So Paul, I'm going to connect with you offline, because I was on I did a talk with Interfaith, it's like ICJUP, Interfaith community for justice and peace. Anyway, somebody on there mentioned if there is a drug that you need, there's a place for like low income people to try and fight to get that. So I will try to reach back out to those people and get that information to send it to you for your friend. So I'm so glad you shared that, because then that made me remember that. So we'll see what we can do. So thank you for sharing that, Paul. And that's awful. That's really terrible that your friend is needlessly suffering when there's a drug that would take her suffering away. Jeffrey Denton has a comment. It says, CalCare, run a ballot initiative like whole Washington is doing in Washington State, ? So the reason why we don't like ballot initiatives is because they always fail. And the reason for that is when it comes to money. So it's like if it's something that doesn't really involve money, you have a better chance. If it's something the people with money want, okay, that'll work fine. But all it takes, Jeffrey, is one commercial with actors that are dressed up as firemen, or an old grandma in a rocking chair that'll say something like, CalCare will kill me. Don't let it kill me. And it's it. You just lose. Commercials cost a lot of money. The medical industrial complex could put, I don't know, 1,000 commercials on a day and not even bat an eyelash. So we will lose. We have lost. This has been done before. Even if you look at other things, when it came to rent control, I mean, that was a ballot initiative. And I mean, they were working hard, and there it was, just one commercial, and I think they had like a fireman, a policeman, and a grandma on, and that was it. You don't even have to convince the public that something is wrong. You just have to confuse them, and this was the tactic that we've seen in the environmental movement. It could be like 99% of all scientists around the world, would say, hey, global warming is caused by, what we humans are doing, and we need to make these changes now. And you would have the one scientist that's paid by whatever corporations just sow doubt. He didn't even have to convince people that the other scientists are wrong, just enough for people like, I don't know, I've heard both sides, and some say it is and some say it isn't. And whenever people are confused, they won't vote positively for something on the ballot. Also, the legislators would love for us to put this on the ballot. And I, having been served as president of the Pacific Palisades Democratic Club for 3 years, having been twice elected as a delegate, an assembly delegate to the California Democratic Party, I've seen how it works. And anytime legislators are receiving money, their donor base, and then when they have activists come in, what they'll do is they'll be like, yeah, I'm really for it. And they'll give you but my hands are tied. I don't have enough power. They do have enough power, but this is what they say. And they'll say, you know what? And they'll make it sound like they're doing you a favor. They'll say, I can't do this, but you know what? Let's put it on the ballot. And anytime that's them shirking their responsibilities. There's no reason why this should be on a ballot. It is their job to legislate. So that's a long answer to your question about why not do a ballot initiative like Whole Washington. If if we do end up having a ballot initiative, I'll work as hard for it as I'm working for this legislation. But it just takes one commercial. So
yeah, you're going up against so much money, right? I mean, think of it this way. I think it was in 2019, approximately $12 million was spent on gun rights lobbying, and we know how big of a lobbying influence gun rights is in the United States. The NRA spending about 1.7 million or something like that. Contrast that to the HMO lobbying industry. You're talking about $28 million, so more than double the amount of gun rights lobbying has been spent in the United States, and Kaiser Permanente alone over $2 million. So if they put that money towards any sort of campaign against a ballot initiative, that is not something that our grassroots activists, etc., would be able to go up against. And that's just HMO lobbying. When you're talking about CalCare, the pharmaceutical industry doesn't necessarily want this either, right? Because it's going to create a much larger negotiating power with CalCare, right? We'll be able to be a much bigger fish to negotiate against pharmaceutical companies, which means that's going to be their bottom line or their profit margins as well. And so you're going to have a lot of people saying, no, this is our profit margin. We're going to put a lot of money against this, irrespective of it being better for humanity.
Mm-hmm. Danette, I'm not sure if you're on, but I know you're a longtime activist. So if you,
Hello.
Hi, Danette. I don't know if there's anything you want to say to weigh in. And also Dennis, if you want to chime in. Danette, we can not see you. We can only see your background.
I'm multitasking.
Okay. So, but I just wanted to welcome you, Danette and Dennis, to jump in and say anything, but no pressure. You don't have to.
Well, I just wanted to say that I went to the Democratic Party of California meeting this morning, and as we know, everything's intersectional. They were not willing to stop taking fossil fuel money, which we know affects people's health. We actually had someone there. I don't recall her name off the bat, but she lives in a highly polluted area with a lot of refineries, and she's suffering health effects from that. So it's just just opposite of what we should be standing for. And it was, needless to say, it was very disappointing, the decision that they made today. So, we get sad and we get down for a day, and then we get back up again and keep fighting. That's all you can do. But it was very discouraging.
And so, yeah, you see, even in this case, right, the money, we are fighting against our own Democratic Party machine, so, right. So that's, you're talking about fossil fuels, but it is all interconnected and it's all the same. It goes back to money. So
absolutely.
Dennis, I see you on Stack. Did you want to come on now?
Yeah, just more to your point to why we shouldn't do a proposition is we all remember Prop 61, which was supposed to do the lower prescription drug pricing through, I think it was collective.
So I got you on this one, Dennis. It was to allow the state of California to negotiate the same rates that the VA negotiates. I mean, so this isn't even single payer. It was just to allow us to negotiate the same. But go ahead, Dennis, take it from there.
No, that was it though. I just, yeah, I mean.
That failed.
Yeah, because of a couple really deceptive advertising campaigns, if I remember correctly.
Yeah, I was working hard on that one. Okay, so let's move on. Chelsea has a question. So she writes in, how would the transition to CalCare work? Because there is so much healthcare disparity based on where you live, people will see providers because that's what's approved, not necessarily where the best care is. I'll take a stab at this, Dr. Huynh, and then if you want to jump on. And you know what, I called you Rich earlier, but I think I just prefer to, like, on your radio show that we're on, on your podcast here, I think I should refer to you as Dr. Huynh. So yeah, so this is one of the great things that CalCare does, Chelsea. We have healthcare deserts right now, again, because our healthcare industry is not based on patient need, but it's based on profit. So if you go into Beverly Hills, we have Cedars-Sinai Hospital, we have all kinds of doctor offices and clinics, but if you go into some rural areas or some other, financially struggling areas in the city, they've closed hospitals, they've closed clinics. So this is one of the things that the bill prioritizes, is it prioritizes the building of hospitals and clinics in these healthcare deserts. So that begins to shrink the disparity that we are seeing in healthcare. And I know Dr. Huynh will vouch for this, but delayed care, is denied care, because the longer you delay someone's care, the worse it can be. So if somebody gets injured where there's, no hospital or no clinic to go to, and they have to travel a long distance, I mean, that's time lost. So that's one of the things that CalCare does, is it immediately starts building and bringing in a healthcare community with doctors, nurses, et cetera, in areas where there are none. Also, there would be no more approval like we have now. It's, if you, like in Marine's story, when she was in Spain, she got sick, she walked to the closest clinic, they took her. She didn't have to have a referral. It wasn't in network or out of network. You would have a CalCare card, and that's it. You just go wherever you need to go, the closest place, and you get care. So there's no more networks. There's no more approving or referrals. Dr. Huynh, do you want me to reread the question, or you got it?
No, I got it. By the way, Chelsea, this is a great question, and it's definitely laid out in AB 1400 as to how the bill is going to help with the disparities of care issue that we have in California, or actually in all of the United States. First, I want to say something about disparities of care in general. There's several layers to this, right? So again, talking about the intersectionality of health and healthcare amongst other issues, part of the reason why we have such disparity of care is because of sort of the very racist redlining practices that have been going on for many years. Certain areas were allowed to have loans given out so that they can make improvements into their infrastructure. And that's why we have, places like, Cedars-Sinai and Ronald Reagan UCLA Medical Center, all being, miles with one another, and yet, try to find another quaternary care or tertiary care, hospital in South LA, it becomes much more difficult. You have a much larger distance that you would have to travel, and so that's part of it. But a large part of the healthcare disparity is because of the health insurance industry, right? It's because people are beholden to their employer-based insurance programs, which have limited your access to care to approved providers or in-network providers, etc. Right? So, for instance, here in South Bay, Los Angeles, right? There are, I would say 15 to 20 pulmonologists. I'm a pulmonologist, but when you're talking about networks, you're kind of beholden to your 5 or 6 pulmonologists, or in some cases even less than that, because of whatever insurance program that you're under. So by opening up networks, by creating a single payer system where now you can choose whichever provider you want, you're going to have access to a far larger distribution of care, and so that will help with the disparity issues. Furthermore, AB 1400 has provisions where it's going to look at these healthcare desert areas and try to increase funding to those areas to try to improve the healthcare in those areas. And so it's definitely addressed, and it would definitely make healthcare disparity much better. So I think the transition to CalCare would be fairly seamless, because remember, what we're talking about is creating a single payer system so that healthcare is publicly funded, but essentially privately delivered. So same doctors, same hospitals, everyone's still, I would still work for my employer, right? But now I'm allowed to see any patient that I want. And that's huge for me, because, as someone who practices not only in a hospital setting, but also in a clinic, that allows me to see a patient in the hospital, right? And then afterwards, I'll be able to follow them after their hospitalization. Now, oftentimes, unfortunately, because of insurances and then whatnot, I'll see a patient in the hospital and I'm not allowed to see them again afterwards, despite having taken care of them for days or weeks. I'm not allowed to take care of them anymore because their insurance won't allow it. That would take away that problem. So that's going to be huge for doctors, because it just makes our lives so much easier, that you can have that continuity of care.
And also, talking about disparities, one of the things that AB 1400 outlines is it integrates multilingual, culturally competent care so into provisions for healthcare equality. And so this is really important, and something we haven't seen in past single payer bills in at least this state. So are there any other people that want to weigh in on this? If not, we will move on. Let me see, this might just be a statement from Jeffrey Denton. I'm not sure. It says, I have a list of 116 countries of various populations and GDPs that all have universal health care, but supposedly the richest country on earth can't afford it. World Population Review has the list of 116 countries. Yeah, great point, Jeffrey. So California is uniquely situated to start the healthcare revolution by passing AB 1400 and then leading the rest of the country in the greater fight of healthcare justice. This is how it was done in Canada in the 1960s. It's their single payer system started in one province, the province of Saskatchewan. And from there, then the whole nation adopted it. And that was at the same time, roughly the same years, the United States implemented Medicare, and basically Canada implemented Medicare for all. They did it at the same time. That was in the 1960s. So another thing about transition is, the infrastructure is already there. So I think it was 1964 that we got Medicare. I don't know if anybody wants to validate that or correct that, but we didn't even have the computer technology then that we have now, and Medicare was up and running all over the country in 1 year. So thanks to Medicare and Social Security, I mean, we already have the basics of the system there. So it's not a very difficult transition. But going back to Jeffrey's point, so in some other states have done some attempts towards single payer. I don't know that they were really truly single payer, but in some other states on the East Coast. But one of the issues they faced was, let's just say, I'm just picking New York as an example. A lot of people maybe work in New York, but they live in New Jersey. And so it kind of brought some challenges there. But California is a large state. Pretty much if you're working in California, you're living in California. California is the world's fifth largest GDP. The world's fifth largest GDP. And we are about the same population as Canada. So the United States can afford it, California can afford it, and it saves money. So there was single payer SB 562. If that had passed in 2017, by 2020, the state of California would have saved $111 billion. Imagine how much we could have done with that money during the pandemic, $111 billion. So yes, we can afford it. Exactly, Jeffrey. Let's see.
I'll fact check you, and you're close. 1965.
1965. Okay, I was off by
1 year.
1 year, and
that's close enough for me.
Yeah, and then Paul Newman also jumped in there. 1965, Johnson signed the bill. You know, on the note of the pandemic, when I said, you know, California would have saved $111 billion. AB 1400, if passed, will have us better prepared for the next pandemic. And there will be more pandemics. And the reason for that is because it costs money to be prepared. So think about your earthquake kits at home, right? You had to buy that, you know, whatever it was, that carton of water, but you save it. You don't drink it in that moment. You have to buy whatever it is, your flashlights, your mask, whatever, and you save it. And so our hospitals are run like hotels. When a bed isn't filled, they see that as they're losing money. So they don't want to have extra beds that would only be filled if there was an emergency, but CalCare changes that. So we would have equipment, beds, you know, just things that we need being maintained, being there, being stored, being maintained, so that when an emergency hits, we're not scrambling, at least in that respect. So CalCare better prepares us for the next pandemic. Paul, did you have something to add? Oh, yeah.
Yes, I'm reading Tom Hartman's The Hidden History of Healthcare, and he talks about the fact that the United States could actually buy all the health insurance companies and in 2 years pay it off. In other words, it would be paid back in 2 years if we had a single payer system. And it's just amazing. I mean, we could do this, and I just can't believe it. It's a solution for homelessness. It's a solution which includes mental illness, addiction. It's a solution for so many things, and it would get rid of so much corruption that we have currently with our politicians and everything. So I just wanted to comment about that we have the capability, no problem. And plus it would say, you know, GDP is something like, it's 24% of GDP, according to the Kaiser Foundation. And we would be paying 7% of GDP. if we went for a single payer system. Even in California, we'd be saving $40 billion or more. So that's—
Yeah, thank you so much, Paul. And maybe you want to drop the name of Tom Hartman's book in the Facebook chat in case people want to check that out. And thank you so much for sharing that with us and that information. That is fascinating. I did not know that. Oh my gosh, it's so good. I want you to repeat it. But yeah, that's really interesting. And then, yeah, I remember Dr. Bill saying last week that, the figures were worked out by economists that single payer would save about $1 million per person. So that's incredible. And Paul, you mentioned about, people suffering from diseases of alcoholism and drug abuse and things like that. AB 1400 includes drug rehabilitation, substance abuse recovery. So that is spelled out in the bill. And I love that that is recognized in this bill as a healthcare issue. Our country has done a very good job of making that a criminal issue rather than a healthcare issue. And people suffering from these issues are suffering a healthcare crisis and need help. They don't need to be jailed for it and punished for it. They need help. Yeah, Paul, I see your real hand.
Just to add, people don't realize, we're trained to think that on a microeconomic vision rather than a macroeconomic vision, micro being small and macro being the whole picture. And the whole picture is this: it's going to cost us far more money and any taxes that would be charged if we were to have an increase in tax, and it would be significantly small, but it would cost, the cost of the way it is now is so astronomical. But if we have a single payer system, that cost would drop significantly. And it's just like climate change, the damage that these hurricanes are doing, and flooding and droughts and fire, is far more expensive than what we would pay for a green bill that would alleviate that would carbon sequester, that would outlaw fossil fuels. I mean, it's just amazing. But we're taught to think the wrong way. We got to think on the big picture, that it costs far more to neglect it. And it's costing us far more now in human life to neglect it. So that's my 2 cents.
Yeah, and you really, again, you really highlight the intersectionality, Paul, of it all, of the climate crisis, the healthcare crisis, the humanitarian crisis of our unhoused fellow American residents. They're all interrelated, and it is far less expensive to deal with the problem in a whole way, rather than, like, as you're saying, as a macro way, than plugging it here and there.
I wanted to circle back on the pandemic preparedness part that you were talking about before, because I think that I remember reading that section, because there's actually a section in AB 1400 where they talk about sort of pandemic preparedness. And I remember how, like, to me, it was, when I read it, was, when we're in the height of our own pandemic, our current pandemic, and it brought a smile to my face, because it had already sort of started talking about those things. I mean, it was such a great response. So the way that I remember early pandemic, there was a time where a lot of hospitals did not have PPE, right? They didn't have N95 masks. They didn't They ran out of gowns. They ran out of all sorts of different things, gloves, things like that. And I remember at the time, I would get phone calls from colleagues working at various hospitals saying, hey, do you guys have any, whatever it was, masks or gloves or equipment? And we would sort of try to coordinate with one another, like, almost like this black market of, I'll give you like, 10 boxes of gloves if you give me, 4 boxes of masks, and we try to trade with one another just so that we can protect ourselves, right? And to make sure that we can give patients, proper care without endangering ourselves or endangering others. And I remember talking to my hospital administrators about sort of this issue. I was like, why are we not, how did we run out of equipment? How did this happen? And the way it was explained to me in the end was kind of fascinating. It was that, hospitals are sort of run like restaurants, right? You have a certain amount of tables, and you have a certain number of restaurant goers that you anticipate each night. And so you buy enough just to kind of get you by, right? And the reason is because, you got to make sure that, that you meet your overhead, right? That you're able to sell enough product so that you can replenish your supply. And that's the way sort of hospitals are run. They aren't run for anything more longer than that. And that's partly because of how they're paid, right? Their hospitals are paid by insurances or whatnot, and so they get paid per patient, etc. And so there's the thought of having a surplus on hand for hundreds of patients who they don't know where the money would be coming from was not something that was recognized. And it's just because that's the way our system is made. Our system is made in that hospitals are sort of like businesses, right? Hospitals are businesses at this point in time. But for me, and this was sort of one of those moments where I said, oh, that's right. A hospital is a business. It's not a service, right? We tend to think of hospitals as services, right? That's a place where you get your service at. That should be something that's always protected, that you can always get your service there. But no, it's a business. And I think changing how this medical industrial complex works by changing the payer will really revolutionize how hospitals are thought of, or how they're run, because they'll no longer be thought of as a business, and they'll be thought of more as a service, right? It'll be more where they can think of, okay, we know that, we have a single payer system. We know exactly where the funding is going to come from. We have a pot of funds that is specifically laid out for us to be prepared for whatever the next issue is, whether it be a pandemic, whether it be a natural disaster, whether it be anything, that we'll be ready for it. And that, I think that's huge. It definitely would have prevented so many issues with the current pandemic that we had. And you're right, this is the tip of the iceberg. We're going to have more issues in the future. This isn't the first pandemic that's hit our world. We've had pandemics before in the past, and with the way that the world is globalized and with all the changing that's going on, we're going to see this more often.
Yeah, that's right. And these hospitals are businesses, and they're lucrative businesses. So if you look at Prime Healthcare, they have like 42 or 48 hospitals around the country. I think 8 of them are here in California. The owners profit, I mean, so much money, like I can't even, like, it would sound made up. And so, so what CalCare does is it changes it from a business model to a healthcare service. And can you talk about global budgeting, which, you know, AB 1400 talks about, because I think it fits right in with what you're articulating on this change?
Right. So the way that the way that global budgeting would work, it's one of the forms of payment that is described in AB 1400. Essentially, what would happen under this beautiful new world where we have CalCare would be that there'd be a single pot of funds, money, that will be distributed, and it will be distributed to whether it be individual physicians in a fee-for-service sort of platform, or global budgets will be given to hospitals, skilled nursing facilities, long-term care facilities, etc. And what it will be is that in cooperation with the hospitals, CalCare will sort of recognize the funding necessary to maintain the hospital, or if you're in an area of need, maybe even help facilitate the growth of that hospital. And so I think it was, and don't quote me on this because it's been a while since I last read the text, but I believe on an annual basis, they'll review sort of the budget necessary to maintain or improve upon that facility. And so that will include things like PPE preparedness. They'll include for things like, you know, making sure that the facility gives, you know, cultural and lingual appropriate care, and that money would then be you know, be spent on the budgeting of the hospital, which would include nursing staff, ancillary staff, physicians, etc. And so that's the way that hospitals would be paid by CalCare.
Again, so yeah, that shifts the motive from profit to actually healthcare.
Mm-hmm.
You know, one of the things too that people say is, I mean, like wealthy people, they'll say, oh, I have great insurance and I get the best healthcare. And what they don't realize, and they'll say like, you know, my doctor tests me for this, that, and this, and that's not necessarily great healthcare. What you should be getting is what you need, not more and not less, because you know, that's, again, if it makes the institution money by denying care, then you won't get the test. If it makes the institution money by giving the patient a bunch of tests that they don't necessarily need, then that's what will be recommended. So again, this shifts the model from profit to care. I see something in here, a comment in here by Jeffrey Denton, and I just want to say, oh my gosh, Jeffrey is a part of the Red Berets in Washington. I did not realize that. We are huge fans of the Red Berets, Laura Fielding, whole Washington. So I'm gonna put up a big red heart because I don't have a red apple emoji on my Zoom. But a big shout out to whole Washington and the Red Berets. They are amazing. So I'm just gonna read the statement that Jeffrey put in. He said, I was looking at Wikipedia article about Tommy Douglas, who was responsible for launching Medicare in Canada and was Premier of Saskatchewan from 1944 to 1961, and shared to my group Red Berets for MedicareForAll this morning. Red Berets is a national MedicareForAll group based in Tacoma, Washington, but we network with groups like yours around the country, and PD America and Democratic Socialists and One Payer States. Plus, we have an extensive network of volunteers in Washington State and just about every major city. I know that CalCare is highly organized, and that's why I monitor your progress, but I don't think any state well organized as Washington at this point in time. We are launching another ballot initiative in less than 200 days. So wish us luck, because we're going to need it. I have to agree with you, Jeffrey. Nobody is as organized as Washington State. You guys inspire us. We so appreciate y'all. We love you all. When we're down, you pick us up, and I'm glad to hear that you get some good stuff from us too. We are in this together. We are, our hearts, our fingers, our toes, everything is crossed for your success. For Washington to lead the way and California to follow. And we just so love you guys and appreciate you. So you bet we're sending you all of our luck, all of our love. We're so excited. We monitor you guys. I don't think we used to be better at doing tweets to you guys, but might have fallen off, but give our love to the whole Washington team there. So inspired by y'all. Mwah. So yay, Jeffrey, for being on. Are there any other questions you see, Paul, from Facebook, or yes, you do. And then Dennis, do you have any questions or anything that you want to share? Feel free to just let us know whenever you do. Okay, thanks, Dennis. Yeah, so there's obviously a national movement for Medicare for All, and then there are state movements, basically for state Medicare for All, with the intention that if one state gets it, it makes it easier for the rest of the states to follow. And so, and we also work closely with one-payer states and Democratic Socialists and Progressive Democrats of America. So all amazing. Public Citizen, oh my gosh, they're incredible. So many wonderful grassroots organizations and activists. And so we're all, we focus on what we focus on at the moment, but we're all really in this together and supporting each other. I see Luis Gonzalez wrote, do you work with a union? I not necessarily. I am SAG-AFTRA from 100 years ago when I did, when I was an actor, and I worked really hard to get my union card, and I'm never gonna let that baby go. So I do keep up with my union dues.
I'm wondering, is Luis asking if we have like union support? Is that sort of the potential question that he might
I don't
ask?
know, but I'm proud to share our union support.
I think I'm just gonna use that as a segue to that then.
Do you have the list there, or you want me to try to pull it up?
I think I have the list, but you can add on if I forget anyone. I know Unite Here, Local 2, 11, 19, 30, 49, 483, and 2850. The California Teachers Association, California Labor Federation, California Nurses Association, of course, South Bay Central Labor Council, Sacramento Central Labor Council, UPTE, CWA Labor Council, Labor United for Universal Healthcare, and National Association of Social Workers are some of the few of the union groups that we've gotten support from. I'm sure there are others and more to come. It makes, I've talked to some people in unions before, and ultimately it comes down to this: if it's legislated, it doesn't need to be negotiated. So imagine now if your union doesn't have to negotiate anymore and spend all those hours negotiating for better insurance and coverage, etc. That means that you can spend that time looking at worker safety, worker hours, you know, all sorts of different things that you can
Worker pay.
Worker pay. That's right. Worker pay, for sure. That would be, it's such a game changer for unions. It'd be huge. So so I think it's only, it just makes sense, is what I've heard from certain from people from unions.
Yeah, and I don't know when you hopped on, Luis, but the bill was written by the California Nurses Association, so it was written by a union. But I'm just curious, are there any other members on this Zoom who are actually a part of unions themselves? No. Okay, just curious.
There aren't that many doctor unions out there.
There aren't that many doctor unions,
No.
yeah. And then Paul, I know that you're a musician. I didn't know if you were with the musicians union, and
I was a member of Local 1400 of the Carpenters and Joiners Union, AFL-CIO.
nice, nice.
But I built in theaters.
That's fantastic.
I worked at the Oxford Theater in Hollywood for a while when I was a kid.
Yeah.
That was about it.
That's fantastic. You know, the other thing about unions is, you know, sort of like what we're seeing with the Democratic Party is that leadership is not always exactly aligned with membership. And we saw this with the culinary union in Las Vegas, when the leadership came out with a statement that they didn't support Medicare for All and they didn't support Bernie. And then you actually had the membership write a letter that said, oh, hell no, we do support Medicare for All and we do support Bernie. And, you know, just like with, you know, we see that here in California, our legislators are taking money from hospital associations and, you know, big pharma and insurance companies. Nancy Pelosi takes, I mean, that's her number one donor, is the medical industrial complex. And so a lot of times what they say is different than what the rank and file want. So I just wanted to point that out, that, and also there are positions, you know, when it comes to union leaders, obviously not all of them, but there can be, you know, there are those who, you know, are paid to handle the, you know, the healthcare, you know, all of the healthcare stuff. And so that job probably would go away. So they kind of have an incentive to not want to move to single payer. And, you know, there's, you know, power plays going on and all kinds of stuff that can happen at the leadership level that doesn't necessarily reflect membership. So just pointing out that difference. Oh, so Sia writes in from Facebook, I noticed in the toolkit it is talking with assembly members. Is there a need to talk to California senators? So right now, we're just kind of taking this one step at a time, first things first, and the bill is going to be reintroduced in January in the Assembly. We need it to pass the Assembly first before we get to the senators. So our ask, and maybe Paul, you can drop the bit.ly for our toolkit into Facebook chat, but we are asking that you call your assembly member tomorrow morning and tell them to support and pass AB 1400, which will be reintroduced in January. So we're focusing on the assembly members at this time. So if you would do that, Sia, that would be amazing. You know, write them, email them, get on our newsletter, our email list, because we are about to launch a letter campaign this week, which will allow you, you know, we have the template already written. You can add your personal story if you want, and it automatically goes to your assembly member. So please join us at, I think it's bit.ly, join HCALA, to join us. And we're going to be launching that letter campaign this week. But also, please do call your assembly member and get all your friends and family and colleagues to call in as well. So thank you so much for dropping that question in. That was really, really helpful. I see something from Chris Shimizu, our beloved Chris Shimizu from HealthCareForAll Los Angeles. Let's see. She writes, I was asking about the claims pharmaceutical companies make that there are programs to help people pay for their drugs. How universally accessible are such programs as far as you know? Chris, so I just heard, I just heard about what you're talking about like 2 weeks ago, and I was going to send Paul the information offline, and as soon as I find it out, we can put it on our website, but I did see Dr. Huynn's hand go up. So.
Yeah, I mean, individual pharmaceutical companies will make claims that they always have assistance programs, especially for their more expensive drugs. So you'll see that pretty often. In terms of universal accessibility, it's going to be different for each drug and each pharmaceutical company. For the most part, in my experience, typically they're not exactly universally accessible. You have to really meet a lot of you have to meet certain criteria in order to qualify for these types of programs. So you just have to make just enough money or just not enough in a sense. So it is sort of a it's a certain population or demographic of patients that would typically qualify for these types of programs, generally speaking. So, but they are definitely out there, and every pharmaceutical company will have these types of programs, quote unquote, made available to people. It is from the times in which I've used them with my patients. Some of them can be, pretty difficult to navigate, and so for a person to do it on their own, it sometimes takes a little bit of a willpower, and so oftentimes what I do with my patients is my staff actually has to sort of help them through the whole entire process, because it does take a little bit of time and effort to go through to get those types of medications to be paid.
Yeah, and then how I heard about this story, Chris, which may give part of your answer. So the gentleman who shared it, so it was Interfaith Communities United for Justice and Peace is the group that I was doing a CalCare presentation when somebody shared a story about how they had beloved friends, and the woman had brain cancer and was suffering terribly, and they could not afford the drugs. And so she died. And then he had a wife, he lost a wife to cancer, and his second wife got cancer. And she was suffering terribly. And then somebody told him about this program for low income individuals, because there was a drug that could help her with her suffering. And it was, I don't know, Chris, it was like, it was either double-digit thousands or it might have been $100,000. I mean, it was something crazy, and they could not afford it. But they found out about this, and they did get it, and she did get the drug, which helped ease her suffering. And I just remember when this gentleman told this story, just how he got just so choked up about like how if he had known, he would have told that to his friend. So almost like the guilt that he did not know about this program to tell his friend, but he didn't know. So anyway, Chris, I hope that answers your question, and thank you so much for putting that in there. Dennis, what are you writing in the chat? Just speak up. Unmute.
Well, there's another question by Chris that followed that one. just to let you know.
Yeah, Chris made a statement, says it says, so more money is spent on staff jumping through hoops to help someone be able to afford the overpriced drug. Yeah, that's, you know, that's one of the things that I think goes unsaid, is that, you know, people talk about the cost of health, you know, healthcare, etc. But, you know, a lot of that is because we have to spend a lot of money trying to go through all the paperwork and, you know, etc. because of this crazy system that we have, the, you know, the proverbial what is it, spaghetti thrown against the wall? I forget what term that
That's it.
Tina and Bill like to use for it, and that's what it is. I mean, you know, every time I have a patient and we try to figure out, you know, how to, where we go through these problems and we try to navigate through the system, you know, if it were that you could take the same road to the same endpoint for every patient, that would make it somewhat easier. But the problem is that every patient has a different roadmap. Every patient, you have to go through completely different loophole, you know, loops and bounds, and climb different mountains and hike different trails in order to get you to the endpoint that you need. And so a lot of time and money is spent, you know, doing that. And so with, you know, CalCare, the process would be, you know, pretty much seamless. It'd be so much easier. And you know, it goes unsaid that, you know, a lot of your doctor's time is spent on the phone trying to there it is, trying to navigate this crazy system. And that's time in which we could be seeing more patients, or maybe spending a little bit more time with your patient. You know, how about that? Instead of your, you know, typical, you know, 5-minute, you know, quick visit, they'll be actually able to sit there and talk with you, and, you know, and connect with you. You know, I think a lot of times it's so difficult to do that, because so much of our time is spent, you know, dealing with other things. I'm going to go on a complete tangent here. You know, with all the sort of misinformation about the pandemic and everything like that, it made me really, you know, wonder, you know, if we as doctors, or not just doctors, but even anyone in medicine, had more time to spend with your patient, you know, we'd be able to clear up a lot of the misinformation. We'd be able to have more, or the community would have more trust in science and trust in healthcare, you know, and I think that a large part of this is because we're in a for-profit system. And when we're able to take out that part of this, you know, it'll be about your care. It'll be about the patients. It won't be about profits anymore. And I think it will just be a complete game changer in terms of how healthcare is done here in this country, and here in especially in California, and then hopefully the entire country, right? Anyway, sorry, I always go on a rant.
Oh, no, I'm so glad you did. I think you're absolutely right. The trust is broken in this country. And I hate to say it, but a lot of it for good reason. I mean, look at how much money Pfizer is profiting, okay, off of this vaccine, which I've received the vaccine. I do think that we need, so I'm not saying that, but it's the for-profit system has broken trust. People have done people that know better have done things and said things that I don't know that they would have said or done if they weren't motivated by profit. And the way to repair this is to take the profit out of our healthcare system. And, you know, I believe that there should be a profit for things like, you know, this beautiful sweater that I'm wearing, or these earrings, or my hair color. Yes, I pay for it. But I don't think that there should be profit in basic needs, and healthcare is a basic need. So I think you're absolutely right, that would go a long way in restoring trust. And by the way, that screenshot that Paul Newman put up of we got it from Dr. Bill, but on one side is, there it is, the Canadian healthcare payment system. And then on the other side is the US healthcare payment system. Okay, that's a real thing. That's not a fake drawing with scribble in it. That is actually like, you know, on the left-hand side, it's tracing one bill. And on the right-hand side, it's tracing one bill.
Yeah, and that's the thing that, you know, a lot of times people will look at that right-hand side and they'll think, oh, that's just an exaggeration of our, no, that is our system. I actually, when I first saw that, I was kind of amazed by it. And I thought, oh, that's interesting. That must be, you know, hyperbole. And then I took a closer look and I was like, no, that actually is how things quote unquote work, right? It boggles the mind how something like that could be deemed okay.
So I wanted to ask you, Dr. Huynh, earlier when we were talking about hospitals being run as businesses, I know that nurses are now having to, like, they have this little card thing where it's almost like they clock in when they go in to see a patient and clock out. And it's like, if they are getting penalized, it's like they have so many minutes to spend with a patient. I don't think this is happening with doctors necessarily, but I'm hearing this from nurses, that if they spend too long with patients, that they are getting penalized for this, and that it's starting to be like, you know, you only have so many minutes to spend with each patient. So have you seen any of that or experienced that?
I'll be honest with you, I have not experienced that or seen it. I mean, you know, we try it. I mean, our nurses are fantastic. I don't know how they they work their butts off, and you know, I don't know how they find the time to do the things that they do for our patients, whether it be in the hospital or whether it be the staff that I have in my office. You know, we encourage them to, you know, try to spend more time with our patients, just because we're not, you know, the physicians are sort of limited as to how much time, you know, we can spend, because we only have so many hours in the day, right? You know, so I have not seen that, but maybe I'm just blessed to be working somewhere where they're not implementing something like that.
Yeah, well, I think Maureen might have more information on that, so she can talk about that. Also, too, another thing that CalCare would do, which we've touched a little bit on it, is, but going back to trust and preparedness, it would reinstate a public health care system where we have public health. So Maureen, you know, she started off in public health, which the budget for that has been decimated, but, you know, where she would go into neighborhoods and, you know, have questions and find out, is there lead in their water, you know, things like that. So this is another great thing that AB 1400 would do, is to restore public health.
Mm-hmm.
And so, yeah, okay, I'm just looking at the chat. Randy Hicks, are we going to use the latest study to sell our case on savings? Well, I would think so, Randy. We have the Poland study that was done just a couple of years ago when we had SB 562. But, you know, Randy, this has been studied repeatedly over the last 30 years. You have studies from Yale, from Stanford, you know, so really reputable schools, and even from the most conservative, you know, anti-single payer entities like, what is it, the Cato Institute. And they all show, all of them, that single payer save money without exception. They all show that. So we don't need any more studies. The studies are there. Yeah, we need to get money out of politics. That's what we need to do, or get politicians in who are actually public servants rather than career politicians that are in it to for money and power. Dennis, I know that you unmuted like way back, and then I think you got cut off. And I see like you guys, SGV progressives met with your assembly member staffer this week. Do you want to talk a little bit about that? Because we'd love to encourage other, whether it's a Democratic club or a group, any kind of organization, or individual, you can just get 2 other people to go with you and ask for a meeting. But Dennis, do you want to talk a little bit about your meeting? How did you guys set it up? What did you do? How did it go?
Yeah, so it was this Friday. Sure, shift this around. It was set up by the person who pretty much chairs the Singapore Valley Progressive. Her name's Shahrazad. It's hard to get out a meeting with the actual assembly member, Assemblywoman Rubio. But I think the whole point is to let her know that we're paying attention and that this is really important to us. One of the things we really wanted to do was get into some sort of a commitment from them, either to support the bill or at least, seriously consider it. Don't know that we got, I definitely didn't get the support, but the staffer said they're definitely going to look at it. But really the important part is to make sure that you're contacting your representatives. Right now, you said it earlier, the most important representative to contact right now is your assembly person, just to let them know you're paying attention and that this bill is really important to you. And if you can get a group of people together who have personal horror stories regarding our current healthcare system, that'll really work well for you. Mine being, I'll very quickly say that I was having to pay the medical costs of several friends and family members via GoFundMe was my horror story, but there was a few others who had some even worse stories than mine. So the point is, contact your assembly person. Get it if you can, get a group of people together. Request a meeting with them. If you can get the actual assembly person, great. If it's just the staffer, that's do that. Any sort of contact is good contact, and just make your case for why CalCare is really important.
Yeah, so we have a toolkit. I think it's bit.ly, lowercase do you CalCare, uppercase T, uppercase K, or you can just go to our website, hcala.org, and click Take Action and click CalCare. And in our CalCare toolkit, we have, it's a website you can go on to. I think it's findyourrep.legislature.ca.gov. And you just put in your address and it'll tell you who your assembly member is. It'll give you their phone number, their email, their address, and you just call and say, I'm a constituent and I'd like to make an appointment. And, we encourage you to go with 2 or 3 friends, ideally who are also constituents in that same district, because it's just, much more fun to go with friends than to go it alone. And we have talking points in our toolkit. We have fact sheets. And basically, the main ask is you want them to support AB 1400 when it's reintroduced. And, you can ask them, why don't they support it? What will it take to get them to support it? This is hugely popular in California. I think it's something like 80+% of Democrats support single payer, and like over 50% of Republicans support it. So it's it's hugely popular. You know, Dr. Huynh talked about the gun lobby. You know, over 90% of Americans support background checks, over 90% across the nation. And yet we still haven't gotten background checks. But yet, you know, we're a democracy where our representatives represent the will of the people. It doesn't make sense. So you see, you know, again, high percentages of people here in California who support single payer, and yet we still don't have it. It's not the people in the way, it's the legislators in the way. So
I just want to say thank you to Dennis and the SGV Progressives for meeting with the staffer. It's huge. It's you know, we met with our assembly member, and I remember I sense a lot of empathy with how Dennis was bringing up his meeting with the staffer, and you kind of leave there going, gosh, you know, I don't know how well we sold that to them, or, you know, if they really caught the message and this and that. But, you know, every little bit counts. And I think the more that our assembly members and their staffers hear from us, the more they are they are inclined to have to listen, right? Like they can only turn a blind ear for so long. And as long as we keep on pounding them with the same message that this is what your constituency wants, and this is what is best for not only, you know, us, best for our health, but also best for us economically and on so many different levels because of these intersections between different problems in the community with health and healthcare. They'll start to realize, you know, that this is something that is going to happen. You know, I have no doubt in my mind that there is going to be a day where this is going to happen. The question is when, and why not just do it now? Why not just have, you know, us adopt an amazing bill that truly encompasses healthcare as being a human right, and that's what it should be all about.
Well said. So Randy Hicks weighs in and says, this is why Californian Hospital Association opposes cow care, because they want the money to be first resolution or ER visits. Any comments on that, Dr. Huynh?
Yeah, I mean, again, it's, you know, hospitals are businesses. You know, a lot of hospitals are multi-billion-dollar. You know, it's a multi-billion-dollar industry, and you know they're looking at their bottom line. They don't want things to change because they're doing so well right now, right? I mean, it's their business is quote unquote booming for them, you know. But you know, it's imperative for us to take the profits out of this industry and make it about the patients being first. So yeah, I mean, it's true. This is why we're up against you know, we're up against so much lobbying powers, because they want to keep, you know, they want to keep the status quo.
Okay, another really, Jeffrey Denton, Red Beret from Washington, has put in a fun fact, and he writes, Japan has had single payer since 1938, and Japanese people live an average of 5 years longer than Americans. Norway has had a single payer system since 1917. So you would think that if it didn't work, they would have changed to something else by now. Thank you, Jeffrey, for that fun fact. You know, also going back, you know, why doesn't America have it, or California, since we're so progressive? We participated, HealthCareForAll Los Angeles participated in a national day of marching for Medicare for All. Dr. Huynh spoke at the march. And I think it was every state, a city in every state participated. So we all marched at the same day around the same time. And we marched here in Los Angeles. And there was Daniel Lee. He is a member of the Culver City Council. He's a Culver City Council member. And he spoke that day, and I was really struck by his story because it's a story that I haven't heard this take before. But basically, and he shares this publicly, so, but he has had ongoing medical issues that he's had to deal with. And he talked about getting his treatment after he was elected a city council member. And he said what he had to pay for it as a city council member was doable. But he said, but if he had gotten this treatment before he had been elected to the city council, it would have basically, it would have saddled him in debt for I don't know how long. And, you know, and he really highlighted that once you get into, you know, elected offices like at the state level and above, you, and maybe some lower offices as well, but they get healthcare for the rest of their lives. And it's pretty much, it's basic, it's actually socialism. I mean, it's not socialism, but it's basically single payer, because it's like they, you know, they get it from the government, and they, so even when they leave office, they still get those healthcare benefits. So, you know, our elected officials that we are begging and pleading to support a bill for the people to have healthcare are not now and will never be in the situation where they are needing healthcare because they have it. So I just want you to keep that in mind as you go about this fight. Paul Newman writes, we should do billboards. Paul, you know, do you know how much I love billboards? I'm such a billboard fan. Yes, I want to do a billboard. I love billboards. So that brings me to, if you want us to do a billboard, please donate. Put 5 on it. I think, what's our bit.ly, Paul? Bit.ly.
I'm getting it now.
Donate HCALA, or you can just go to hcala.org and click donate. I would love to have enough money to put up a billboard. Right now, we're spending our money like just infrastructure, like Action Network, to send out our newsletter and our campaign letter that we're going to drop next week. But yeah, so would love for you guys to donate, would love for you guys to join. Paul's going to drop those links to donate and to join. And then also want to let you know, tomorrow night, Monday night, we have our general meeting, which begins at 6 p.m. And Paul, if you're interested in joining that, it goes from 6 p.m. to 7:25. I know that's a very specific number. And that's because at 7:30 p.m. we have our speakers presentation. So tomorrow night at 7:30 p.m., please tune in on our Facebook page. We will do it Facebook Live, and our Facebook page, you're already on it. It's HCA Los Angeles. And what our speaker presentation is on tomorrow night is on the intersectionality and all of the grassroots organizations working together to pass this bill. So I believe we have members from DSA LA coming on. We've got Feel the Burn, San Fernando Valley. Those people kick ass. We love them so much. And there are several other organizations. I'm not sure which ones, but would love for you, because Maureen organized our speakers event, as she always does. She's amazing. So please tune in tomorrow night on Facebook at 7:30, and we'll talk more about what you can do as individuals, what you can do with groups of friends in your organizations, how you can join these efforts. So would love for that.
Sia just messaged in that she resubmitted a form to meet with his or her, I'm not sure, sorry, Sia, with my assembly member on Facebook Live. So thank you so much. That's fantastic.
Yay! Woohoo! This office hours was a success, Dr. Huynh. I know we were nervous because Gina is usually our hostess with the mostest. She's an RN. She is on hiatus right now. We love her. We miss her. Dr. Bill Honigman, he is on every Sunday, but he had something with Progressive Democrats of America today. So we miss him. And then Maureen Cruz, we didn't have her. So I was like, sorry, Dr. Huynh, you just got me. But but we did all right because
I'm sorry you had to reach down and pick me out of the barrel. So
well, you're a rock star. So but look, we got somebody to submit, to go make an appointment with their assembly member. So thank you so much, Sia, for that. We appreciate that.
Awesome.
Are there any other questions? We've got about 15 minutes left. Oh, Randy Hicks says our assembly member is a co-author. Who's your assembly member? Hey, let's give a shout out to Hcala. Hcala, so the nurses sponsored this. This is such weird language. I don't know why it says they sponsored it because they actually wrote the damn bill. But, and then Cara is the author. I mean, again, this is like legislative lingo. But so it's not that he actually wrote it, but without Cara, we wouldn't have a bill in the assembly. So he's the one that put his name on there as author and made it happen in the assembly. Hcala is really a champion for this bill. We meet with him regularly. He is working so hard, and these people on this Zoom will vouch for me. When I say somebody's working hard, they're really working hard, because just authoring the bill would not cut it for me. Co-authoring the bill would not cut it for me. I mean, this guy is putting in the time, the energy. I mean, he is really fighting for this bill. The two other principal co-authors are Miguel Santiago, who is also working very hard on this bill, and Alex Lee. And so they really are champions for this bill. Funny enough, Cara and Alex Lee they're from the same area, and Maureen jokes she doesn't know what's in their water up there, but those are the only two California legislators that don't take any corporate money, is Hcala and Alex Lee. So please give Osh and Alex some love. I think Alex might be in the middle of, running for his seat again. I mean, I know there are some people, and by people, I mean corporatists, going after him. So give Osh and Alex some love. Give Miguel Santiago some love. They are really championing the bill. And please give a thank you to all the co-authors. We so appreciate them being co-authors. And we're hoping that the co-authors will have town halls. So if you're a constituent of somebody who's a co-author, please thank them for that. It's really important. Let them know how much you appreciate it. We certainly appreciate it, and ask them to do a town hall, because I think it would be very powerful for the co-authors to do a town hall. So, yeah.
Randy says that his assembly member is Assemblymember Kevin McCarty, who is a co-author, co-sponsor for the bill. So shout out to Kevin McCarty.
Shout out to Kevin McCarty, and have a town hall. We'll come, we'll join, we'll help you set it up. That's awesome. Thank you so much for sharing that, Randy Hicks, not to be confused with Rusty Hicks. Let's see, any last words, Dr. Huynh, or summing up? I made Paul Newman laugh.
Gosh, last words. Well, CalCare rocks. I think one of the things was really interesting is sort of, serendipitously or spontaneously during this, podcast that we just had, you know, we were able to bring up like several points of how healthcare has such intersections with, you know, different issues, you know, whether it be the housing crisis or the crisis of the unhoused, disparities in healthcare and disparities with regards to race and gender and etc. We talked about climate change and how that intersects also with healthcare. And so it's just interesting how healthcare kind of brings it all together as well. And that just reminded me with the climate change thing. I forgot to mention this, but you know, I just wanted to, I guess it's kind of a PSA for those viewers who are in the city of Carson or in the surrounding areas of Carson with the hydrogen sulfide sort of leak that's going on over there. You know, definitely stay inside at night, you know, for the time being while they try to clean up that mess. And, you know, if you start developing any, you know, worsening or concerning symptoms, you know, I know that a lot of people are having like headaches and sort of some minor respiratory issues, but if you are starting to have something concerning, if you're starting having vomiting or anything that makes you worried, please seek medical attention. I've certainly seen a number of patients coming from that area that have had some pretty serious exposure. So keep your house sealed, stay indoors, especially at night. Try to get some air filters at home, and if need be, if you can, try to find someone that they can you know, crash with outside of Carson, because it is a problem, and I've definitely seen patients who've suffered because of it. You know, and so just a quick aside about that, because, you know, and these things, unfortunately, with the way the world is, they happen, and that's why we need CalCare. We need, you know, people's lives and health to be not taken for granted, and that, you know, healthcare should be a human right. And so and we know that whether this was natural or whether this was, you know, from some sort of leak from one of those refineries, I don't know exactly. I have my suspicions, but, you know, these things are going to happen more often. That's why we need to make sure that our community is well taken care of.
Yeah, and again, the intersectionality, we see the environmental racism in this, that goes right to the healthcare disparities, right? So they're linked, and the needing to stop fossil fuels and move to cleaner energies, like immediately. So again, it all is all interrelated, and I appreciate you saying that. Bronwyn had been leading a protest for several days with, you know, there was the leak out there, and then the refinery happened, and so she is our environmental warrior who sees the links, and so thank you so much for doing that. I know we only have 8 minutes left. Randy Hicks put in what to do about Senator Pan and the CMA. And I just want to say really quickly, Randy, that I think you'll get different answers from different activists. Some activists will say, I don't know, love them until they change. And I'm kind of more of an activist that says, you know what, don't even waste your damn time with them, because there are some people that just aren't movable on this, but there are other people who are more in the middle that you could move. So, but what would you say, Dr. Huynh?
You know, I think it's, yeah, I think there's several different approaches. I think letting it be known that we're there, and that, you know, look at the numbers, you know, the numbers support, you know, single payer, whether it be Democrats, whether it be Republicans. California, this is what California wants, and just remind Senator Pan that this is what the people want, and it's the right thing to do. With regards to CMA, you know, the CMA, it's fascinating to me, the influence that CMA has for an association that the larger majority of physicians do not care about. You know, like it's not, it definitely, CMA is definitely not the voice of doctors. It's not, you know, and they like to take up that mantle that they are. But the reality is it's the voice of the industry, of that same medical industrial complex. You can see where CMA gets a lot of their funding and money from. You know, hopefully they'll get with the times and they'll understand that, and they'll come to realize that, you know, that that things need to change within that organization. But that's essentially what that organization is.
I love that. CMA, you don't represent the doctors.
Yeah.
And also, Randy, then we would have other people that say, find out where they live and show up on their front lawn with a bullhorn. And that's how you can deal with PAN and CMA. So, yeah. And then I see your last comment here, Randy, about mosquitoes are migrating north carrying dengue fever. Dr. Huynh, can you talk about the Lancet put out a report saying that, you know, I'm going to butcher it, but the Lancet recently put out a report basically saying that the environmental crisis is like the greatest risk to healthcare we are now facing because of things of like, you know, of what Randy's saying. You'll have lakes and streams drying up, right? Temperatures rising, and that just affects so many other things.
Yeah, I mean, you know, it's kind of what we've talked about in that, you know, there's such an intersectionality between, you know, climate and health, and with climate change and how it affects you know, our water that we drink, our food supply, our nutrition, the air that we breathe, right? These are all, this is what we're bathed in 24/7. This is what our life source is. And so if we don't have good clean air, good clean water, good food, good clean nutrition, like that's going to cause quite a detriment to our health. And when you have dirty air, dirty water, dirty food, that is a breeding ground for infections, for whether it be viruses, whether it be superbugs, whether it be anything really. And so, you know, how we need to think about is at a broader scale, how do we protect ourselves, is we need to start with making sure that we create an environment around us that is clean. And we need to protect ourselves by making sure that we have appropriate health care. And so it just, you know, it just makes sense. You know, I think that it's one of those reports that, you know, if you ask anyone in medicine, it's sort of, we knew this was going to happen. You know, we all knew this was going to happen. All of us know the effects of how climate change and the environment will affect our health.
Well, thank you so much. And with that, we are right at about time. So remember, CalCare saves money, saves lives. Contact your assembly member to support and pass CalCare when it's reintroduced in January. If you like today, put 5 on it, donate to HCALA. You can go to hcala.org and click donate. You can go to our website, click take action and CalCare. You'll find our toolkit. I'm sure Paul has also dropped all of that in the chat. Tomorrow night at 7:30 p.m., join us for our speakers presentation. You can join us on Facebook right here, HCA Los Angeles. And next Sunday is Halloween. So we are not going to have CalCare office hours next Sunday. So the next CalCare office hours will be November 7th. So until then, stay active and hopefully we'll see you tomorrow night. Thank you all so much. Big hugs.
Thank you, everyone.
Good night.
Good night.
Good night.
Thank you, Paul, for running web
You're
and
welcome.
Zoom.
Thank you, Paul. And thank you, Dennis, for joining us on the Zoom.
Yes.
Yeah, and thank you, Dr. Huynh.
Oh,
All right.
Thank you, Dr. Huynh, too. Thank you, Erika. You did an awesome job.
Good night, you guys.
Good night.
yeah.